Good morning, everybody. We're going to have Dr. Mosey Bennett speak about our featured study this morning, and I'm just going to make some notes. We've been talking about some microphone issues. If you're hearing people cut in and out, we're just going to have to really work on positioning because that's part of the issue. So please be patient on the webinar, and we'll get started.
Good morning. So I'm going to take just a few minutes to tell you about an ongoing trial here at the Minneapolis Heart Institute Foundation called DREAM-HF. So thanks for your time. So DREAM-HF is a phase 3 double-blind placebo-controlled clinical trial. It's one of the largest stem cell trials of its kind. It utilizes a mesenchymal precursor cell, or MPC strategy. MPCs are bone marrow-derived cells from healthy donors. They're expanded up and stored for later use. They're available off the shelf, essentially. And there's proven efficacy in animal and clinical models of heart failure and myocardial injury. So the primary objective of DREAM-HF is to determine if the transendocardial delivery of MPCs is effective for the treatment of chronic systolic heart failure. MPCs are injected into viable myocardium using a NOGA mapping system. And the primary endpoint of DREAM-HF is a composite endpoint of cardiac death or heart failure event. Now, this is the important slide, the inclusion criteria. We're looking for ischemic or non-ischemic cardiomyopathy patients with an ejection fraction less than 40% that are currently on a stable heart failure and diuretic regimen with New York Heart Association Class 2 or 3 symptoms. These patients should have been hospitalized for heart failure within the last 9 months or visited an ER for heart failure or have an NT-proBNP of greater than 1,000. An update in terms of study progress. As of September, across the country and internationally, there have been 423 patients enrolled, 66 sites. Here at MHI, we've enrolled 10 patients, and that puts us actually in the top 10 in terms of enrolling sites. And there was a recent interim analysis of efficacy and safety involving 270 patients, and that was successful. So if you have questions about the study, if you have patients that you think might meet the criteria, I'm happy to talk to you, or you can talk to our research coordinator, Jane Fox. Thank you.
All right, good morning. Before I start, I just want to say that please keep your thoughts and prayers for the people of Vegas. Now, for this morning, I have the pleasure of talking with you guys about some of the new things that's happening in cardiac MR, and I hope that you guys will find this clinically fruitful here. Now, the conflict of interest, I have none. And I'm going to follow a case-based format just to make things a little bit more interesting. I'm going to talk about what's T1 mapping and what's extracellular volume and how it applies in a clinical scenario. We'll talk about T2 mapping. We'll also talk about use of cardiac MR in patients who have devices, whether it's conditional or non-MR conditional. So we'll jump in the first case or first patient, a 69-year-old gentleman. I actually saw him at St. Francis as an inpatient. He has history of poorly controlled hypertension, medication noncompliance, sleep apnea, obesity, so the classic cardiology patient. And he was admitted because of community-acquired pneumonia. And why a troponin was checked, I'm not certain, but it's elevated. So a consult was generated. And this is the patient's EKG. So On the left here is when he came in. Now, there's nothing overwhelming in terms of ischemic changes, but you see he has kind of left axis versus left anterior fascicular block. He has poor airway progression, and these changes were not present a few years back. But again, nothing to suggest there's ischemic changes. An echo was done. Now, I interpreted this echo, so if you disagree, be gentle with your comments here. But so when I looked at it, my concern is, one, he does have quite a bit of LVH, and the septum seems to be a little bit more exaggerated compared to the other areas. The EF is not really robust, and this is not playing very well, but I estimate probably around 45% or so. His apical images were tough, so IV definity contrast was given. Again, the septum looks thicker than what is other areas. Now, the question is this hypertensive cardiomyopathy, ischemic cardiomyopathy? He does have coronary disease. Does he have HCM? Does he have amyloid? Or we don't know. So should we complete the follow-up and say he came with pneumonia, he has no symptoms suggestive of heart failure or ischemic heart disease? So should we say echo is done and we're okay? I kind of want to pull the audience. What do you guys think? Hey, John. Well, Mike, you're reading my thoughts, my goodness. My concern is, one, is that to me it looks like there's some evidence of HCM. Now, granted, he has hypertension and many risk factors to make heart look like that, but we did proceed with the cardiac MR. And this is what we call SSP cine imaging. This is a bright blood sequence. You don't have to give contrast. This is kind of the workhorse sequence that we do to assess EF, to look at wall motion. 2-chamber, 4-chamber, 3-chamber, and kind of the mid-shore axis view. Again, you can see the septum is quite a hypertrophy, but other area is also thick. The EF was calculated out to be 45%, and then there's 21 millimeters in terms of wall thickness. So he certainly has LVH. So now, does this help us? Is it hypertensive? Is it ischemic, HCM, amyloid, athletic heart, Anderson, Fabry, something else? Don't care.
So far, it's just a better echo.
Okay. All right. So what should we do next? Well, we gave contrast. Okay. And this is gadolinium. So these are short axis views. This is at the base. This is at a mid-ventricular portion. So RV, LV, this is the cavity. This is the myocardium. So, and I won't pick on anybody. So what this is showing is that you have diffuse gadolinium uptake throughout the myocardium. It's circumferential, and it's basically transmural. So when this happens, there's two scenarios. Number one, this is real. Okay, this is some type of diffuse fibrosis that we're seeing gadolinium everywhere. Secondly, is that number two is that could this be a technical difficulty, a technical issue, where that on occasions with this particular sequence, you have to have some amount of normal myocardium to compare to. LGE sequence, or gadolinium enhancement sequence, is relative to normal myocardium. So is this real or is this not real? So with that, this kind of brings into why do we want to do T1 mapping and why is this a good thing? But kind of historical perspective, what's wrong with what we have right now? We've got plenty of good things going on. Well, traditionally, the way we look at whether it's a diseased heart or it's a healthy heart is looking at an EF and looking at the morphology of the left ventricle. With MR, we can give gadolinium, and that's kind of the non-invasive gold standard in looking at SCAR. And we know SCAR is important because it's fundamental to the development of myocardial dysfunction and many different types of cardiomyopathies. But we know delay enhancement underestimates the degree of interstitial fibrosis, and we know that because there are many patients, and many of you guys sample cardiac MR, where they have dilated cardiomyopathy, their EF could be 10, 20%, yet there's no delay enhancement, there's no SCAR. And autopsy series, they clearly have some degree of interstitial fibrosis. So in the setting where you have diffuse fibrosis, again, you need to have, at least for MR, you need to have some normal myocardium to be as a reference, to be relative to. And there's also a small percentage of patients, obviously, that cannot get gadolinium because of nephrogenic systemic fibrosis in part of their renal dysfunction. So what is T1 mapping? Well, I'm just going to spend 2 seconds on physics here, okay? So T1 describes how quickly proton recovers after it's been flipped by radio frequency pulse. That's it. That's all the physics I'm going to talk about. So what we're really measuring is we're measuring T1. So why does T1 matter? Well, because it's the fundamental property of tissue. T1 is high if there's a lot of water. T1 is low if there's fat. So what T1 mapping is basically we're creating a map of the T1 values. With that, we're able to generate a pixel-wise map, okay, a color pixel-wise map. And then this allows you to determine T1 anywhere in the myocardium you want. So it can quantify, okay, the global and also the regional disturbance in the myocardial structure. And because it spits out an absolute value, it doesn't have to be relative to normal myocardium per se. It allows you to detect focal and diffuse fibrosis without gadolinium. But in essence, it's allowing you to look at the tissue composition. It is changed in disease states. That's what makes it helpful. So it can serve as essentially a histological biomarker. And I'll talk a little bit more about it can allow you to derive what's called extracellular volume if you give gadolinium. So now, native T1 or T1 really means the T1 before you give contrast. What increases T1? Well, myocardial water content. So protein, fibrosis, they all increase T1. So cardiomyopathies, amyloid, HCM, MI, myocarditis, they all increase T1. Now, depending on what paper you look at, and again, if you search far enough, you're going to find results that kind of go with what you want. For this particular paper from Fontana, this is in Great Britain, and most of the data comes from Great Britain, actually. T1 is sensitive and specific enough that you can tell the difference between AL amyloid versus ATTR amyloid. So you can tell the hereditary amyloid away from AL and AL away from senile amyloid. The difference is also enough you can tell HCM. And in fact, for patients who carry the mutation for hereditary amyloid, if they don't exhibit LVH or phenotype amyloid yet, their T1 is actually within the normal range compared to healthy controls. Now, this is the T1 map we generate from our patients. You can see this is, again, a pixel-wise map, a color map. This is a short axis at a base. This is at a mid-ventricular level with the papillary muscle, and this is at the apex. And we can generate where a T1 measure in this patient is 1,152 milliseconds. Normal in our lab runs anywhere from 950 to the 900, so high 900 to 990 or so. Now, you can do an AHA model where you have a 16-segment model where you have the apex, the mid, and the base. But most studies have shown if you just do a region of interest, especially in kind of diffuse processes, you're going to get relatively similar values. So again, region of interest at a septum, region of interest at a lateral wall, and again, the native T1 is going to be pretty similar. Now, there are a few things that actually decrease the T1 value. Condition called Fabry's. Now, this is relatively rare. It's basically LVH, but it masquerades as though it's amyloid or HCM. Because of a lack of an enzyme called alpha-galactosidase A, it can accumulate these single lipids in the cell, and with that, it can decrease the T1. If you have iron overload, cardiac siderosis, because of iron, it shortens all the parameters essentially in MR, T1, T2, T2 star, and in fact, it's been shown to be more sensitive than traditional sequence we look for iron overload, which is T2 star. Now, again, this is Sato and all, and this is from Great Britain, and they look at how useful it is to detect Fabry's. And if you use a cutoff of 940, it's very sensitive and specific to Fabry's. The trouble is if you look at HCM, aortic stenosis, and hypertensive cardiomyopathy, there's a significant overlap in terms of the T1 value. Now, beyond T1, if we give contrast, then we can calculate something called extracellular volume. And that's a way you can actually quantitate, okay, the volume percentage of interstitial space. And that has really high agreement to histologic measures when you biopsy the patient. So basically, it's a correlate of myocardial collagen, so fibrosis. And it's particularly useful in patients that have a lot of interstitial fibrosis. So for example, amyloid, HCM, AS, and so on. And ECV correlates very well in terms of prognosis. You don't have to remember the formula, but what you do need to know is in order to calculate extracellular volume, you have to have contrast. And we can generate a T1 map before contrast, after contrast, and then we can calculate the extracellular volume. So for our patient, on the top, okay, that's the T1 map before contrast. Remember, the T1 is high. Normal should be less than 1,000. For our patient, it's 1,152. Then we can generate a map post-contrast, and that allows you to calculate the extracellular volume. Normal extracellular volume should be somewhere in the 25 to 30% change. Also, for this patient, it's quite high with an ECV of 46%. So, based on those data, okay, our concern initially could be, is that truly diffuse fibrosis, or is that something, a technical issue that's causing the image acquisition? Based on the extracellular volume being over 40, 50%, you know that this is true disease. And in fact, this patient has amyloid. So, and there's plenty of data to support use of ECV. And what I have found is that in patients who have just the ATTR variant, and this means hereditary or senile amyloid, the higher your ECV, the worse your outcome. Now they use 58%. This is primarily to generate a graph. It's not a binary percentage. If you're 57%, your outcome is great. If you're 59, it's terrible. It's not quite like that. There's clearly some increase as the ECV increase. And you can see again, if your ECV is high, your outcome is less desirable. For our patient, the biopsy confirmed that he indeed had cardiac amyloid. Mass spectrometry shows that it is an ATTR variant. He underwent genetic testing, and he has the most common valine isoleucine mutation, and that's hereditary amyloid. Based on our data, based on his ECV and his BNP being elevated, although it's only mildly elevated, the likelihood, at least based on what we have right now, his prognosis is more on the desirable side than the high risk of decompensation. So after he recovered from pneumonia, he kind of returned to his baseline functional status in the setting of hypertension and morbid obesity and sleep apnea. Next, I'll jump into the next patient. This is 72. He came in because of urinary retention. And I wasn't moonlighting as a urologist, but he did have atrial fibrillation, so I saw him in consult. His history is otherwise negative. He's a healthy guy. The only thing he was limited by was his back, which he had back surgery recently. And this is his only EKG we have. It shows he has some interventricular conduction delay. He has poor R-wave progression. Looks like he might have a kind of left axis deviation. Otherwise, he has no past medical history. And this is his echo. And let me see. Steve, why don't you tell me what you think about this echo?
The size of the LV artery looks okay, functionally good. Does a little thick.
Yeah.
Compared to long fraction, just visualize a little thick.
Yeah, no, absolutely, and I agree. So the concern is that we often talk about is this kind of a sparkly appearance. Now that's not very specific, especially with harmonic imaging with echo, but it does look bright. Okay, and when it's bright, you think about, well, does this patient have amyloid? So again, he came in because of urinary retention. He was relatively asymptomatic, so I saw him, rate control him, sent him out, and ordered a cardiac MR as an outpatient. Of course, 2 days later, he promptly came back with heart failure. Mario.
You guys look at the echo attention, and the RV, I mean, to me at least, looks big too. I mean, thick.
Yeah.
Does that make any difference when you look at it? I mean, does it sway you in one or the other way?
Yeah, no, absolutely. So RVH can occur with amyloid. So one of the trouble with RVH is depending on what views you look at. Okay. So if you look at the apical images, the way the ultrasound probe is placed and where the ultrasound goes this way. So the longitudinal resolution is not going to be, if you look at the longitudinal resolution will be better if the wall is this way. So you're perpendicular to it. So then you can determine the LVH. So if the wall is this way and you're trying to determine the wall thickness, so you're talking about lateral resolution, and that's not as good. Okay, so you can overestimate or underestimate the wall thickness. So really, I think in echo, the best way to determine LVH will probably be from either the subcostal view or from a parasternal long axis views. So, and again, you're obviously limited by your resolution and so on. So of course, the patient came back in with heart failure, and this is after I told him he probably has amyloid. So that doesn't help in terms of how he feels. And this is his cardiac MR. Again, this is the SSFP cine without contrast. And you can see that patient has a lot of LVH, a lot of muscle. The atria are really big as well. You can see he does have RVH, as you said, Mario. His EF kind of is on the lower end of normal. His atria is big. So obviously, you look at this, you're concerned for amyloid. We gave him contrast. This is 2-chamber, 4-chamber, short axis view at the base. You can see the gadolinium uptake throughout, okay, from base to apex, there's gadolinium everywhere. Same thing here, the SCAD uptake, the SCAD take in RV as well, in the atria. So again, we'll go back to the same scenario. Is this a real disease, or is this something because of a technical issue? Because when there's no normal myocardium, it's very difficult to null the myocardium, to null to what we call as normal, and to see what abnormal looks like. And for this patient, ECV, again, is very helpful. So his native T1, right here, this is the native T1 map. This is a 4-chamber view. Again, very bright. This is the blood pool. So remember, blood has water, so it's going to be very bright. So bright means high T1. More purplish, okay, it's a lower value. This is the native T1 map. It's elevated at 1,165. This is the map after you give contrast. And we were able to calculate his ECV, and it was 69%. Again, normal being 25 to 30. And his BNP is also more elevated at 410. Genetic testing was done, and he has the wild type, the senile form of amyloid. This is, again, a review article from Great Britain, where they look at where does the ECV run and where does the T1 run in terms of different disease processes. And when it comes to amyloid, again, ECV can be very, very high. If you look at the T1 and the ECV right at the scar, right at the area of infarct, the ECV is also high. It's important in that for Fabry's and iron overload, the T1 map is actually, the T1 is very low or lower than normal, but the ECV could be relatively normal. And again, other processes kind of can get into the area where the T1 values can overlap. So again, for this patient who we know has wild type amyloid, his ECV is over 60% or 67, you can see his prognosis is less favorable. And his BNP being higher may play some role as an indicator as well. I'm going to skip over the treatment here for the sake of time. I'll jump to the next patient. This is 57. Again, it's like a copy of the first patient. 40 control hypertension, his blood pressure is 171 over 108 in clinic. He's morbidly obese. It's obstructive sleep apnea. He came in with shortness of breath. This is his first EKG. Nothing really overwhelming, some non-specific changes. And this is his echo. So Dave, what do you think?
Well, it looks like there's normal left ventricular systolic function, probably left atrial enlargement, right ventricular size and function, and right atrial size appears normal. A little bit of aortic valve sclerosis, that's what I can see so far. Those walls are thick.
Yeah. So again, you can see that there's some left ventricular hypertrophy. Maybe the basal septum is a little bit thicker. Again, so is this HCM? Is this amyloid? This is only a 50-some-year-old guy, but again, he has hypertension. He's morbidly obese. So where are we in this spectrum again? So do we complete a workup and say this is hypertensive cardiomyopathy, let's control his blood pressure and be done? Or should we look into other things? And I don't think there's actually a right answer to this, but as an imager, and I want an answer, hopefully the right answer, we did an MR. So again, 2-chamber view, 4-chamber view, 3-chamber, short axis view at the base. You can see there's a lot of muscle. There's a prominent amount of LVH. Its atria is enlarged. You can see the LVH is pretty diffuse and not just isolated to one segment. We did T1 mapping. You can see his T1 value is a little bit elevated at 1,024. And his ECV is calculated at 26%. Again, the normal being somewhere between 25 to 30. This is delayed hyperenhancement imaging. You can see there's no scar except a tiny, tiny area at the inferior RV insertion site, which is a non-ischemic pattern. So then, is this hypertensive, ischemic, HCM, amyloid, athletic heart, or Fabry? Well, I think we're pretty comfortable. It's not ischemic cardiomyopathy. Okay, there's no ischemic scar. It's not amyloid because its ECV is actually pretty normal. It's 26%. I think we can eliminate that even without looking at the echo, probably. So it's not Fabry because its T1 value is actually high and not low. Now, can we be 100% sure it's not HCM or it is hypertensive cardiomyopathy? No, I don't think you can be absolutely sure. But based on the data we have, it's most likely hypertensive cardiomyopathy. So we know native T1 mapping and ECV provides prognostic value beyond just EF and beyond delay enhancement. It's also helpful beyond patients with amyloid or hypertensive cardiomyopathy. It's helpful in patients who have non-ischemic cardiomyopathy. And again, this is from Great Britain, over 600 patients. And they have found the higher the T1 value, the worse the prognosis, the lower the survival. Presence of DE, and we know this, if you have DE or delay enhancement, your outcome is worse. And the weakest prognostic indicator is actually LVEF. Whether it's EF is 35 or lower, did not make a huge difference, at least in this population. This is from Pittsburgh, and where they look at the ECV, and when for every 3% increase in extracellular volume, your outcome is worse. And this is just in graph form, the highest tertile of ECV, the lower the survival, the highest, the more likelihood that you're going to need a VAC or a transplant. More recent data about a near 500 patients, again, same. When you have higher ECV, your outcome is worse. When you have lower ECV, you have more desirable outcomes. All right. So let me jump to the next one. This is 38-year-old, previously healthy, came in with 6-month history of shortness of breath and had recent syncope. Troponin 0.09. EKG kind of showed really non-specific changes throughout, right axis deviation. And it looks like the voltage is relatively high, but it's only 38. This is his echo. Now, he had an echo in 2016 because he had palpitation or something. And now this is his echo on the mission. Well, I'll just talk about it. So I think here, relatively unremarkable. About a year later, you see some evidence of LVH. EF remains normal. Left atrial size might be a little bit bigger. These are the apical images. Maybe a little bit more LVH. Atria definitely looks bigger. Okay. So this is a young guy with LVH, potentially new LVH, came in with minimal troponin elevation and syncope. So cardiac MR was performed. And you can see his EF is normal. The LVH is present, although not 20. It measures about 16 in somebody who really has no history of hypertension. We did T1 mapping. Okay, so his native T1 value is 1,180. Again, that's abnormal. This is the post-contrast T1 mapping. With these two, we were able to calculate the extracellular volume, and it's 50%. So you know this is abnormal. This is some type of cardiomyopathy. The issue is what kind. Delay hyperenhancement imaging, 4-chamber, 3-chamber, short axis view. You can see there's gadolinium throughout, from base to apex. Gadolinium uptake in the atria, inner atrial septum, gadolinium uptake in the RV as well. So the gentleman has amyloid. So the biopsy showed that he has amyloid. Mass spectrometry showed he has an AL type. And bone marrow biopsy showed he has plasma cell myeloma. There's also outcome data in patients like this. What they found is that using T1 mapping alone without contrast, where if your T1 is greater than 1,044, again, this is not binary, it's that the higher the T1 you have, again, the worse the outcome. The higher your extracellular volume, the worse the outcome. So we know ECV is very strong in terms of prognostic value. So let me summarize. So T1 mapping is a non-invasive characterization of the myocardium. Previously, we can only do it with biopsy. So it's a new histologic biomarker. It improves diagnosis in difficult cases. And it's very important in terms of refining risk stratification. It's not hard to do, but it's hard to do well, just like everything. It's very promising. However, there is significant overlap in disease processes. HCM versus hypertensive cardiomyopathy versus AS, you will overlap in terms of the T1 value. Furthermore, it depends on the magnet strength, whether it's a 1.5 Tesla or 3 Tesla machine. They're going to be normal. The value of normal is going to change. Whether you have Siemens or Toshiba or Philips, you're going to have different normal T1s as well. So there's no clear standardization of normal, and protocol is going to vary from institution to institution. Hey, Jay.
Yeah, what is anatomically going on in the myocardium to increase extracellular volume?
Well, what we think is interstitial fibrosis. So replacement with collagen, replacement with protein, and that's it. So what ECV is really measuring, okay, is measuring the interstitium and also measuring the intravascular volume in the myocardium. Okay, that's what ECV is. So if you have a lot of collagen replacement, and the classic example is, for example, amyloid, or a lot of protein replacement, then the ECV volume will go up. So it's protein, water content. So if you have an infarct, for example, and you test just, if your region of interest is just at an infarct site, the ECV will also be very high. That's right. Yep, essentially. Yep, absolutely. So. All right, so I'm going to switch gear here, and we're going to talk about T2 mapping. So, and this is a 15-year-old kid, came in with acute chest pressure, troponins over 20. He had an echo done at Children's, normal EF, no wall motion abnormality. And I think, the differential diagnosis is probably relatively short in everybody's mind. So what do you want to do? Do you want a cath, CTA, MR, all of the above? Or is this a clinical diagnosis? We're done. His echo is normal. I want to kind of see what the group thinks. Okay. Well, I think you're biased. And the CT. Okay. All right. So this is, again, the SSFP cine imaging without contrast. This is our workhorse sequence. 2-chamber, 4-chamber, 3-chamber, short axis view. In fact, you can see there's actually a subtle area of wall motion abnormality right here in the basal inferior wall, subtle area in the basal inferior lateral wall, and kind of in the anterior lateral wall as well. So when we look for inflammation or edema, the traditional sequence we have is something called T2 stir, okay? And this allows us to kind of qualitatively looking for edema. Normal should be this kind of grayish color. Abnormal should be really bright, So kind of like here or this color. All right. So this is the short axis view at base, mid, and apex. So I think there may be some edema here. It seems like a little bit brighter, but this is qualitative. I'm much more convinced that there's edema here in the mid-inferior wall and mid-anterior wall. The apex doesn't look like there's anything going on. So why should we do T2 mapping if we have a sequence like what we have? And those were very robust images. Well, the traditional T2 weighted imaging, as I said, is qualitative. It's very subjective. Breath hold and rhythm can really cause trouble if patients can't hold their breath if they have arrhythmias. And also towards the apex, when you have stagnant blood, it can contaminate the myocardium. So look as though there's edema when there's not. We know that T2 will also increase with water content. It's very similar to T1 mapping in a sense, is that we're going to create a pixel-wise map, and that's generated from, again, a T2 decay curve. And that's all the physics you need to know. So with any acute inflammation, the T2 will go up and allow you to quantitate the edema. And so it is essential in cases where there's no apparent delay enhancement, but you suspect there is edema, or when gadolinium is contraindicated, that would be helpful. So on the top, this is the traditional sequence that we have, T2 stir. And then remember, we talked about, well, maybe there's some edema here, there's edema here, and nothing here. This is what we call T2 mapping. This is without contrast. You generate a pixel-wise map, again, very bright, okay, meaning high T2. Blood pool has a lot of water in it, so very bright. When it's kind of this, I don't know, low purplish color, it's a lower T2. When you have this kind of orangey color, that means it's elevated T2. So you can clearly see there's edema right here in the inferior lateral wall. There's edema here in the inferior wall and also in the anterior wall. And there's also edema towards the apical inferior wall. So when we compare it to delay hyperenhancement imaging, you can see there's extensive delay enhancement in area that correspond to area of edema. Again, inferior wall, anterior wall, and towards the apical inferior wall. So I'll skip that. So that's helpful in the sense that, number one, you know that's myocarditis. You know that's not infarct. So the MR is diagnostic enough where we can really skip any type of anatomical evaluation. So why T2 mapping? Again, we discussed this. Is number one, the traditional MR protocol in patients that come in with myocarditis, inflammatory cardiomyopathy, or stress cardiomyopathy is looking at wall motion, looking for delay enhancement, and using edema sequence that we have previously, something called STIR. It's problematic in the sense wall motion can be very subtle. Delay enhancement may not be there, especially in patients who have Takotsubo, and STIR has some of its technical issues. This is a study from Ohio where they compare patients who have myocarditis or Takotsubo to healthy controls. And healthy controls, T1 in general is less than 59. And when you compare to remote region of somebody that come in with myocarditis, Takotsubo, those area has the same T2 as patients are healthy. And on the other hand, in the area of edema, in general, the value is over 60. And they found using T1 mapping, it is very sensitive and very specific, whether you compare to healthy controls or compare to remote segments where there's no edema within the patient. So this one is a 73-year-old gentleman, stroke, diabetes, sleep apnea, hyperlipidemia, came in with shortness of breath. It was acute onset. He's working at a Viking stadium, troponin minimally elevated. Again, EKG, nothing really specific. And this is his echo. And so looking at that, I think everybody hung on their mind, this is probably stress cardiomyopathy. You can see that the mid-ventricular segment towards the apex is severely hypokinetic to akinetic. Again, mid-segment toward apical segment. He had a cath, and it was non-obstructive. And this is his MR. Again, this is SSFP cine imaging without contrast. You can see from the mid-segments on, there's wall motion abnormality, hypokinetic in the mid-segments. The apex is completely akinetic. This is a short axis view at the base, and you can see the basal segments are completely normal. And this is in a situation where edema is very helpful. On the top, T2 mapping, again, without contrast. On the bottom, the traditional T2 stir images. You can see, looking at these images, it's hard to tell whether there's any edema at all. Again, 4-chamber, mid-short axis, apex. Again, purplish, normal myocardium, kind of orangey, meaning elevated T2 value, and it's edema. And you can see from the mid-segments on, there's edema. You can see there's edema throughout the myocardium and edema in the apex. And this is not qualitative. You can quantitate this. You can either do a complete map, or you can draw a region of interest. And these values were all over 60. Delay hyperenhancement imaging show really there's no delay enhancement in areas of wall motion abnormality. The patient actually have a subendocardial infarct in inferior lateral wall. And the T2 value in that area is actually relatively normal, so you know it's not acute, and this is chronic. So T2 mapping identifies area of injury even in the absence of scar. You can distinguish acute from chronic events. It's a quantitative assessment as opposed to kind of an eyeball evaluation. And it avoids some of the typical STIR technical difficulties. So I have some time, so I'll go over kind of use of cardiac MRI in implantable devices, ICDs, pacemakers, and so on. So this is a gentleman I follow in a clinic. He has ischemic cardiomyopathy. He had an anterior MI and an ICD placed because he had persistent LV dysfunction. This is a non-MR conditional ICD. He was admitted for left and right heart cath because he came in with a 2 to 3 week history of shortness of breath, chest pressure. Troponin was really normal. And this is his angiogram. Mario, what do you think? Maybe I should find a...
You know, the RCA looks pretty good. You have more pictures than that, or?
Yeah, well, you can see, and I'm sorry, I know the history, so it's easy for me. He has an LAD stent, and you can see he has a lot of disease within the stent. Yeah. And then there's clearly collaterals going into the LAD from the RCA. So the issue is, should we fix that? So obviously the concern is, does he have any viability at all in that region? And so this is the patient's delay enhancement imaging. The reason I pointed out this is where the generator is. And you can see that there's nearly basically transmural infarct in the LAD distribution. So we decided to treat the patient medically. He had some nitrite, and then he did quite well. And now I use that case to illustrate is that over 2 million patients in the U.S. has ICDs and pacemakers. And it's estimated about 50% will probably need MRI sometime in the future. Not most of them need cardiac MR, but brain, back, and so on. The initial concern is always that with the magnetic strength and with the radio frequency, you can actually impair the pacemaker or defibrillator. You can also heat up the tissue-lead interface and cause damage to the myocardium. So initially, that was an absolute contraindication. In the early 2000s, they inadvertently did MRI on patients that actually had these systems, and they all did well. So there was a study looking at about 400 patients that underwent 555 MRIs, and vast majority had no issues at all. So right now, we do MR on patients who have non-conditional devices. These are all reviewed by the MRI reader, and we have our electrophysiology colleagues to help us where the APPs and the pacemaker clinics are involved, and they will interrogate the device and then interrogate it again before and after, excuse me. And let me kind of skip this. And one of the issues that we run into with MR is artifacts when you have a pacemaker. So the most important thing when we order a test is that we want diagnostic information. We don't want more questions. We want answers. So what happens at times is that in the past, with traditional delay enhancement sequences, is that the generator will create such an artifact you can't really evaluate the LAD distribution. You don't know whether there's something underneath or not. Somebody much smarter than me came up with what's called a wideband sequence, which you don't need to know what that means, but it's a delay hyperenhancement sequence where we can avoid this type of artifact. So this is traditional sequence, and this is our patient with a wideband sequence, and there's no artifact at all. So this will allow you to have diagnostic information and treat your patients appropriately. Now, there's still some absolute contraindication that this may change with time in patients who have non-conditional devices. Those who have epicardial leads, those who have abandoned leads, those the implant was less than 6 weeks, or patients where there's certain changes in their pacing mode that we cannot make. But if you have any questions, obviously we're here to help, and this is kind of the algorithm as to which patients should have an MRI. Now, obviously, if you have an alternative test that's just as good, then MRI is obviously not indicated. But if you think MRI is indicated, then this is something we're able to provide. The last case is a 57-year-old gentleman. He's from Canada. He's healthy, actually. He was training for a marathon. And he actually noticed suddenly he has a drop in his exercise tolerance. He was noted to have heart block, and they put in a pacemaker, and an MR-compatible pacemaker. He came to visit. He had some event he had to attend in the Twin Cities. He was in a hotel when he developed acute onset palpitation and pre-syncope. EMS was called. He was found in BT. They shocked him once. Echo showed he has normal LV function. RV was a little bit big, maybe some mild dysfunction. Maybe I have Dr. Gornick tell me this is his pacemaker strip that they looked at.
So it shows that at the top one, it shows the onset, and then it looks waveform suspended means it's sinking, and then charges in the lower right panel with the discharge and conversion.
Yeah, and this is an AED actually. They shock him externally and stuff. Yeah. So the concern, yeah. So the concern then becomes is what does he have? And in somebody who has heart block who was young, then you worry about does he have sarcoid. So an MR was ordered, and he has, again, a compatible device. His generator is up here. And you can see this is a workhorse sequence, SSFP Cine. LV functions normal, 2-chamber, 4-chamber, 3-chamber, short axis. His RV does look enlarged, and the function does look mildly decreased. This right here is the pacemaker lead. And these are sequences where we look at the lung. This is called a Hayes sequences. You can see he has an enlarged mediastinal node, peritracheal. He actually has a big axillary node as well. Delay hyperenhancement imaging was performed, and you can see he has these skip lesions as low as moth-eaten. Lesion here, here, here. This is 2-chamber view. So you have kind of skips. This is not contiguous. Multiple areas in a septum, inferior wall, septum, lateral wall. Again, some subepicardial, some transmural. Specifically dedicated to look at the RV. This is kind of the pulmonic valve, the RVOT view, and there's a lot of delay enhancement in the RV as well. So there's no debate this is sarcoid, and that's why the patient has syncope or pre-syncope in VT. So, and it has been shown that any delay enhancement in patient who has delay, in patient who has sarcoid, the outcome is worse. This is again in a graphic form. If you have delay enhancement, your outcome is less optimal. Let me skip some of these stuff, but ECV and T1 mapping, again, they're complementary tools to what we have. It is a way we can characterize the tissue, so it can help with diagnostic and therapeutic decision making. T1 changes in the myocardium occurs in patients who have cardiomyopathy. Could we use this in following patients who are receiving cardiotoxic drugs? Maybe. It may serve as, again, a non-invasive histology marker. It allows you to kind of risk stratify the patient beyond gadolinium enhancement. Now, is it ready for prime time? Probably not as a standalone sequence, and in part because of overlap with different cardiomyopathies. But again, the most helpful thing is that with the sequences we have, it allows you to further risk stratify and make some diagnosis in patients. And again, just as with any test, you got to interpret it within the clinical context. T2 mapping is a very robust tool for us to look at edema, looking at inflammatory cardiomyopathy. The good thing about it is relatively insensitive to cardiac motion and respiratory motion, allows you to quantitate edema as opposed to, say, subjective eyeball look. Again, cardiac MR is safe even in non-conditional devices. Obviously, protocol has to be followed, and the sequences are robust enough we can provide diagnostic information. All right, thank you very much.
David, thank you. I hope people can hear me online. I'll shout for the room. I have one question, one comment. The question is with regard to amyloid. One of the things that I often look for or hear about is it's hard to null the myocardium. Is that less useful, or how does that fit in this context? Because I think overall this is a great summary of the mapping that you guys are doing and helped me understand some of what goes into how you generate those final reports.
Yeah.
I'm curious if you could comment on that.
Yeah, so nulling of the myocardium really means that we have, so delay enhancement imaging is the way the sequence works is that you have to compare to, it's relative to normal myocardium. So when you have amyloid, when there's diffuse fibrosis, basically you have no normal myocardium to null to. And that's why when we say the nulling is difficult. In that itself, it's actually a trigger to say, hey, is this actually infiltrative cardiac disease? However, just like any test, if there's technical issues, it can cause that as well. So, and that's why when we do T1 mapping, and then you have an ECV that's say 50%, then you can feel very confident that's real.
You are still using that as a first part.
Yeah, and then so with amyloid, the diagnosis really requires contrast. With T1 mapping, they say potential that if patients cannot have gadolinium because of their renal dysfunction from amyloid, that we can use T1 mapping alone without contrast. Now, if their, for example, T1 map is over 1200, then you feel very confident that's amyloid.
Sure, and the pyrophosphate scanning, I suppose, could be helpful there.
Only in, obviously, the ATTR variant.
Okay.
So.
And then the second thing I wanted to mention, this is more of a comment just in general, that people may not be aware, and again, this isn't directed at you, but as you went through these cases, I thought almost every single one of these are the kind of patients that we as a heart failure section would be happy to see. Amyloid, sarcoid, myocarditis. We often are thought of as the LVAD and transplant team, but I want to highlight for people that these rare myopathies with a poor prognosis are also something that we're happy to help see. And incidentally, just as of today, as I understand it, it has gone live with CMS that we're now considered an independent specialty and actually able to bill as consults rather than as follow-up. So for right now, if you asked me to see a patient, I would have to bill it as a follow-up. But I believe, and I have a message out to Tom Talley to confirm this, our visits are now considered consultative, much like if you were to ask Dr. Gornick to see your patient. So just wanted to highlight that today because I think some people may not know that these are myopathies that we're happy to see.
Hey, John.
Great talk. It was very clear. Thank you.
Thanks.
When you send a patient, someone sends a patient and they get a cardiac MR, how much of it should be described as to what they're looking for and what the problems are? How much are we available to interact? And do we do a sequence, all of these sequence on everybody, and then look at it later?
Yeah, I think for now, we have been doing T1 mapping on everyone as it allows. And in part, the reason we do this is allow us to establish what is our normal, okay? What are these sequences reliable in our institution? Now, anyone with cardiomyopathy, I think we should proceed with T1 mapping. Now, whether we should describe everything in a report, I think we can discuss what should go in the report, because the goal of a report is to be helpful, not to be confusing. So one of the things is that we know for sure that T1 mapping and ECV is helpful in terms of prognosis. Now, just telling you that the prognosis is poor, does that get you anywhere? Well, no, but I think it will be helpful in the future in terms of studying how we can help these patients better. But for now, we are doing it on everybody that comes in with cardiomyopathies.
Just one other follow-up. If I'm a referring doctor, and if you just send someone for an MR, and there's not enough information, then that's problematic. We may not do the right thing because you can't look at it retrospectively and get things we don't start.
David, very nice talk. Nicely done. I had a question. What is the experience with T1 and T2 mapping with the transplant patients? Will it help with rejection or some other assessments that is clinically relevant?
So there's, when I look through, there is some study, but they're small, looking at T2 mapping in rejection. And they do found that the value does go up depending on the grade of rejection. But again, it overlaps quite a bit. And research on T2 mapping essentially has gone away now because all the focus is on T1 mapping. Everything is about T1 mapping now. So I haven't done a lot of study using T1 mapping for rejection. And Terry's actually right. It's very helpful in the sense because most of the transplant patients, we actually don't see much delay enhancement at all. In some patients, obviously, we can't give gadolinium. I think for T1 mapping to be prime time, we got to make sure we know, again, what are the normal values, and we got to be able to narrow down and actually distinguish different disease processes because right now there's still quite a bit of overlap. And will we get there? Maybe, and then we'll just have to see. So, hey, Jay.
Dave, one of the things we're interested in is myocardial salvage and ischemia reperfusion injury, and to that extent, the area at risk. And I'm just wondering, it seems more and more, there's more and more issues with that. And what's your sense on the limitations of really measuring area at risk?
Yeah, so, traditionally, you look at area of edema, okay? And then you look at area of infarct. And then you're able to determine how much has it been salvaged. So T2 mapping is excellent for that. But again, as I said, really the research has gone away from T2 mapping. Everything has gone to T1 mapping. Now, T1 mapping will also detect anything that's acute, just like T2 mapping. Now, sometimes you can distinguish whether it's chronic versus acute. So that's part of the issue. So again, I think you'll be able to determine the area of edema, then look at the area of infarct. And the difference in that is basically the area of salvage. So I think that the technology is robust enough where you have to do it in combination. We just have to make sure we can really hone down what is normal, what is abnormal, and our confidence have to be strong enough to give you a clear answer. So.
I'll just make one comment about CMRs and devices. The devices are conditional, they're not safe. They still have to be analyzed before and after. The MRs have to be done in a place like ours and to do it down on the street or shop. The other thing is that it's interesting to me this contraindication for epicardial leads and abandon leads. If you think about it, it's because they don't have a sink anymore. They don't have a sink for the energy to go except to the tip of the lead. So what happens to the tip of the lead? I don't pretend to understand the exact physics or physiology, but the tip heats, and as a result of that, you get increased threshold. But if the epicardial lead is not connected to something, does that really matter to you? Occasionally, you can fibrillate a heart, though, by putting a lead tip, and there are obviously reported cases of that sort. But it's still very uncommon. It's less than 5%, probably less than 2%. So I think rather than saying contraindicated, you should always be thinking, well, I mean, how badly do you need to test? I mean, if it's just like, well, I need an MR on my knee to see if something's wrong with the artery, that's probably not a good idea. But if it's a critical diagnostic test for something going on in somebody's brain or whatever, I mean, I think we'll figure out a way to do it is the way I look at it. Is the risk, yes. Is the risk acceptable? That depends on what it is. So just for that.
So do we contact EP to help us figure out?
The answer to that is in the additional devices, the MR program, both the device clinics check them before and after, and for the non-traditional devices, we actually have somebody either present, if it's in a non-cardiology location, or of course in the cardiology location, we have a cardiologist there. And we do check the devices before and after. But the ones that would, and so the non-traditional ones all have a physiologist on the phone to say what we think. But I think if we had a case of somebody with that full epicardial lead, for example, and the information is critical, that, oh, by the way, when I mean critical, we actually have the neurologists and the neurosurgeons weigh in as to how bad they want the test. We don't just, it's just not, well, we'll order it and see what the result is. They actually, the neurologist and the neurosurgeon have to actually commit that this is critical information that's going to change patient care, and then we'll figure out the rest of the way. But I mean, we're here to help patients, right? Isn't that what we do?
All of them pretty much are. The preclinical clinical gives the both the patient, and then they'll send it to one of us, and then we'll review it, and it's not, and then we usually review it after. So it does go through a whole process, numerical, conditional, and then we usually sit in non-traditional ways, both type MRI, and then we doctors can sit in the ones that have guys.
So if you order it, they have a pacemaker, it goes to pacemaker clinic.
Yes, and then pacemaker clinic contact one of us, and then we evaluate it, or even MRI how we go through it.
So I think Dr. Lynn showed clearly there's a strict protocol. We follow the Magnet State protocol for non-conditional devices. For the conditional devices, we follow the recommendations. Oh, by the way, the conditional devices are primarily 1.5 Tesla. They're not conditional for 3 Tesla. So now you'll ask me another question. So what if somebody really needs a 3 Tesla? Well, I don't know. That's a neurosurgical or a neurologist question. And then it would be something I would discuss with the imaging section, or the electrophysiologist would discuss with the imaging section. Go back and forth. Is it worth it or not worth it? So, but I think we have to be very careful not to be cavalier about just doing the study. It's not a cavalier thing. Something you have to take.
Thank you very much,
everybody. Please by and thank our sponsors, Janssen and Pfizer this morning.
All right, thank you.
That was awesome.
I've been doing around a lot.